Good afternoon. I think we are in a good spot. Hi guys, my name is Dr. Jemima John. I am with the Health Equity Collective as well as the Center for Health Equity, and I am thrilled that you could join us for this second edition of our learning series out of the food security work group. I always like to preface these conversations with a quick background. And so in 2019, 2020, we did this basically very comprehensive assessment of organizational capacity to address food insecurity across the greater Houston area. And this comprised of both qualitative and quantitative methods. We really wanted to know what organizations were doing around food insecurity, how they were responding to their target population's needs, how they were providing resources, how they were connecting their patients, clients to much needed resources, and basically how they were engaging with their client population. And so this was in perfect alignment of the food security work group goals, which were essentially, and we're coming up on our 5th-year anniversary, but we really set out to conduct a landscape scan of the food security interventions and programs in the area of Greater Houston, compile these existing learnings, best practices, and recommendations, and of course contribute to the larger food security landscape as well. And so to that effect, what we did out of this massive convening of organizations, there were 75 organizations. What we did was we took these findings and then we, of course, generated a very comprehensive report as well as manuscripts out of that, presentations out of that. One of the things that we really wanted to reinforce was the importance of translating these accumulated findings into learnings, right? How do we create this transfer of knowledge into practice and to building knowledge and efficacy around this topic? And so we decided to launch this set of learning series around that same space. And so this edition builds on this summer's food security and stigma event that we had with Elia Moreno. Fascinating topic, very enlightening, stigma around poverty, really. But as we all know, poverty is the underlying factor that ties many adverse social needs, including food insecurity, housing insecurity, unsafe living conditions. And so many people from different spaces were able to take something from that session. And we're hoping that you also do too today as well. And so we are excited to introduce our first speaker, who is Dr. Allison Karpyn. And Dr. Allison is a professor and she's the co-director of the Center for Research in Education and Social Policy. She's also a professor in the Department of the Human Development and Family Sciences at the University of Delaware. So she is 1 hour ahead. Dr. Karpyn, in her 20 years of practice, has published widely in journals such as Pediatric, Preventive Medicine, Health Affairs, on program evaluation methods, topics related to hunger, obesity, school food, supermarket access, food insecurity, healthy corner stores, and strategies to develop and maintain farmers markets in low-income areas. We are happy to have her on board because she also has hands-on experience working with community-based agencies and institutions, including nonprofit organizations and retailers, to implement and study specific approaches to increasing access to high-quality food in low-income neighborhoods. In 2017 to 2018, Dr. Karpyn served as a Fulbright Scholar. Congratulations, to study food insecurity and hunger in the Bahamas. I'm an island girl, so I'm very excited about that. In addition to her position at the University of Delaware, she is a fellow at the University of Pennsylvania Center for Public Health Initiatives. She earned her bachelor's degree in public health at Johns Hopkins and her doctorate in public policy research, evaluation, and measurement at the University of Pennsylvania. So she brings to us today the research and the practice, and we are excited to have you be the first speaker in our lineup today to talk about your work around stigma. Everyone, applause for Dr. Karpyn.
Thank you, Dr. John. It's funny, I heard your accent a little bit and I immediately went to yes, ma'am, no, ma'am, because as you know, in the islands, you really need to be proper. And
Yes,
I just come out for myself. So it's nice to be here with everyone. Thank you for having me. As Dr. John mentioned I work here at the University of Delaware and at the Center for Research in Education and Social Policy. So these are issues near and dear to my heart. Before this, I was at the Food Trust for many years, where we also did a huge amount of this work. So I'm here to talk to you a little bit about stigma, and in particular, stigma as it relates to food. And this is really building off of a paper that I wrote with Valerie Earnshaw, who is an expert in stigma, but from a different vantage point. She's done a lot of her work in opioid use disorder and also HIV. And so what we really did was try to have a blending of the minds and experiences to use some of the frameworks that have been established. Really, a lot of the stigma work was done through those sectors or areas of work and apply it to food. So that's what I'm going to be sharing with you today. One of the first things that I want to help everyone to understand, if you don't already, is that our definition of stigma has really evolved from when it was first introduced in the 1960s. And you might hear this term on a regular basis and kind of apply your own understanding to its definition. But one of the things that I learned in working with Valerie, and as I'm trying to go down this path of understanding a little bit more about what we can do to address stigma, is to understand more about its real definition and how we understand it to manifest. So today, theorists describe stigma as a social process that's really key to understanding stigma. So you don't actually experience, you experience stigma, but stigma in and of itself is manifested because it is a representation of a social process where many things come together. It emerges when you have this co-occurrence of labeling, stereotyping, separation, also status loss comes along with that, and discrimination within this power context. And so the social process also results in some marks or characteristics and identities. For example, using a benefit such as SNAP, which could then become constructed as an indicator of maybe a tarnished character, or certain people being seen as less than or worse than others. So that's this idea of this social process that comes together when we think about stigma. And when I'm using the term stigma, I'm really referring then to this broad social process more so than a specific mark or a specific characteristic. So I'm going to give you a little bit more background on the basic research and try to give you a couple scenarios to help some of these vocabulary words, which can be a little bit challenging at times, become a better part of your vernacular as you come to understand sort of these frameworks that are behind stigma. So I'm going to start with a grocery example because we're all here in the food world, interested in food policy, where I'm going to start with one example. We're just going to look at this from the vantage of the shopper. So imagine Anna, she's coming in to go grocery shopping, and she is going to be using her benefit. We'll say it could be SNAP or WIC. And in this example, the first vocabulary word I'll introduce to you is the word target. So Anna is actually the target of the stigma. And so that's why she's considered a target in this language. So Anna, let's just say Anna grew up in a middle income home where she often heard negative things about those who had less than her family did. She saw lots of judgments about people, but now Anna has lost her job and she hasn't had enough food in the house for a few months. The food bank has connected her with SNAP benefits, but she's been a little bit scared to use them. There was another time in her life where she had a boyfriend who received SNAP, and she remembers how humiliated they all felt when people rolled their eyes at the store. So I give you this background scenario because in it is captured some of the ways that a person, a target in this case, experiences stigma. So let's just stop here and let me see. So in this case, we know that Anna received some poor treatment in the past. She has an experience with stigma, and this would be called enacted or experienced stigma. So this is one way that stigma can manifest on a target. Another example that came from that scenario is that Anna is now expecting other people to judge her. She's had this experience in her life, and so she actually is expecting an anticipated stigma as well. So the anticipation of experiencing the stigma is also keeping her from going to the grocery store. And oftentimes this is a major focal point for intervention. Then she's also now turned around what she's felt from the way that she's heard and seen other people be treated, and actually beginning to believe it about herself. And that's where she starts to experience internalized stigma, where she feels like a bad person herself because she's receiving or using a SNAP benefit in this case. So now I'm going to transition to the second sort of party in the stigma landscape of theory, which in this case, I made it the checkout, but it's someone who's actually taking the stigma that exists and pointing it at the person, in this case, the target. So here, I'm going to give you the scenario of a checkout person who is going to be perpetuating stigma. So in this case, the checkout person's name is Lauren, and the technical term for this sort of frame within the model is a perceiver. So it's called a perceiver because Lauren's perceiving the stigma that exists in the world, and then they're pointing it at the target, if that's helpful. So there's a few different ways that perceivers enact stigma. And we know that, sorry, one second. Perceivers enact stigma through discrimination, prejudice, and stereotyping. A couple of examples of how this could come to play in the grocery store could be that maybe Lauren, as a cashier, sees that Anna's coming up with an EBT card and she immediately becomes more irritable. So visually, you can tell that she's kind of flustered. Maybe she's beginning to demonstrate signs that she's passing some judgment. She might warn the next person in line that this is going to take a while. She might not look Anna in the eye. And so she's beginning to manifest this social stigma related to using food benefits into these prejudice, discrimination, and stereotypes. So when we think about prejudice, what we're referring to is the concept that perhaps Lauren is communicating that people in poverty who use these programs are just lazy. I feel uncomfortable around them. And prejudice is really defined by the fact that the person who's perpetuating the stigma is describing or in some way indicating that they themselves feel uncomfortable around this person because of their circumstance. That's prejudice. Stereotyping, on the other hand, is the idea that the register clerk might be thinking, well, if she needs benefits, why is she buying this expensive food? Shouldn't she be the kind of person who needs to buy the cheaper stuff? Maybe she's really not as poor as she claims, or she really doesn't need these benefits. So in that case, she's stereotyping this person to, somehow be taking advantage of a system. And then discrimination is where she's actually mistreating the person at the point of the register. So here the register clerk might be thinking, well, if she has any problems with her order, she's just going to have to really wait. I'm not going to take extra time with this person. I'm going to help the other customers first. Those kinds of ideas are what's captured as the definition of discrimination. So the conceptual framework, this is a little bit of a simplified version as compared to the one that is in our paper. But basically, it seeks to help us understand how this social process ultimately impacts the outcomes that we really care about. And so today I'm focused on those related to what I broadly would call food policy and its implementation. And I know that you all have also had a presentation on poverty, as it also intersects with a lot of these same issues. But when we talk about food social stigma, we're expanding beyond poverty alone, but we also recognize that in that understanding comes also the consideration of intersections with race, ethnicity, gender, and obesity, so sort of an intersectionality frame, and also how that also affects a person's experience using a food program or service. And together, those social processes sort of create the way that the stigma is manifest. So let's see. Yeah, so in the manifestation of stigma, we have structures, which in our framework, we talk about being food policy, so all the way at that policy level, but also the environments and any marketing efforts that might occur in our environment. And then we also have the perceivers and the targets. Of course, perceivers then have the stereotypes, prejudice, and discrimination that they're enacting, and the targets are experiencing enacted stigma, anticipated stigma, and internalized stigma. And so together, then those work alongside mediating mechanisms. And this is really where we have the opportunity to do interventions, improving access to resources, considering how we might be able to influence home food environment and any of the psychological or behavioral processes that can support someone, so that we might be able to, in part, decrease any inequities that might occur for those targets in terms of their diet quality or food insecurity. So as we talk about these manifestations of stigma, it's a good place to focus our research, because this is really where we start to see the measurable and changeable opportunities. And this is really where a lot of lessons can be learned from issues that are not food related, but for example, HIV and opioid use disorder, other drug use disorder work that's been done, for many years before. We've just now starting to get into the weeds on this in food. We understand that broad social processes are difficult to quantify, but we can quantify stigma that's manifested within our structures and within people and individuals. And in that way, we hope to have surveys and scales to be able to do that. We don't right now have them tailored to food, but we're actively seeking ways to do that. We also want to measure stigma so that we can understand how bad or how strong it is and how exactly it could impact health outcomes that we really care about. And then, of course, too, as we begin to develop more interventions to change stigma, we'll be able to determine if they're really working. Stigma manifestations are also changeable. There's many examples of evidence-based intervention tools, and I'll share with you a little bit from a toolkit here from other sectors in HIV and substance use disorder that can reduce stigma manifestations and protect people from them. We know that stigma manifestations are really excellent targets for intervention. Oops. I also would be amiss if I didn't acknowledge the importance of intersectionality in these frameworks. We know that these intersecting characteristics and identities do definitely lead to unique experiences of stigma. One individual's experience is not at all the same as another's. And so we recognize that class and gender, ethnicity, race, language, age, and also, sorry about substance use, but the status of their food use or food benefit also all comes to play in terms of how they're experienced and their actual health outcomes. So what can we do? As I mentioned, there are models for stigma intervention toolkits. We don't have one yet that I'm aware of for food, but I think it would be great if we started to really think carefully about how we might be able to put something like this in place. I mentioned that I sort of took some of the framework ideas from these other sectors, and similarly, I think their toolkit models give us ideas of what more we could be doing in the food space. Obviously, we could begin to tackle a little bit more about the structures, both in terms of legal and policy change that might need to happen in order to create less opportunity for the manifestation of stigma. Also communicating more regularly that we have values for diversity and addressing issues related to behavioral design. On the perceiver side, contact and language has really been a key area where I also think that we have sort of a low-hanging fruit, if you will, to be able to have intervention. In particular, we talk about how our in-person interactions work and how ways that we talk about issues related to food, whether it be on the radio or through books, really can have a big influence on the way people begin to understand some of these issues and perhaps release some of the anxiety and stress that comes about these interactions. So we do, we've already spent a good amount of time, I feel like, in our field thinking about language, but in terms of SNAP and WIC, it's really important to think about a person as someone who's using a SNAP benefit, who is not necessarily a SNAP user. Just really paying a little bit more close attention to the way that our vocabulary indicates, judgment or not is very important. I also think that we need to start talking, especially those of us who have used benefits, more about our experience with benefits and the fact that we have used benefits before. I still continue to get, people from all different walks of life who, especially people who've even been part of studying SNAP, who whisper to me that they themselves have had an experience. They still feel the shame of, using a benefit in a grocery store, or, tell the story. I know at the FRAC conference, we had a wonderful presenter who talked in detail about how they would go to the grocery store at night so that maybe they wouldn't be seen, and, really went out of their way to avoid these feelings of stigma. And I think one other way that we really need to start addressing this issue of stigma is to sort of open the door to more people talking about this issue. And I'll just finish up by saying that I recently was on a radio, and someone at the end asked me, well, what more could we do, especially for kids in schools, to eliminate stigma? And I said, well, I think we really do need to start talking. Everyone who's used benefits needs to start talking about how they benefited from WIC or they benefited from SNAP, to sort of lift the cape on these programs. And the radio announcer herself said, I used SNAP and I also was a beneficiary of WIC. And you're right, I do need to stop whispering about the fact that it really helped me get on my feet at a time when I needed it in my life. So I'll just kind of leave you with that idea, because I'm sure there's a number of sort of doctors and physicians and nurses and other people who are working in clinics who have benefited from these programs, and we need to start sharing that it was me too, so that we can start to lift the stigma. With that, I'll leave it over to you, Allison.
Fascinating conversation. Before we get to Dr. Lacko, if you could save your questions to the end, and we will have a dedicated section for Q&A. That would be awesome. So our next speaker today is Dr. Allison Lacko. Dr. Lacko joined FRAC in October 2020 and served as its research scientist. She provides expertise on research projects, including research design, analysis, and applying an equity lens throughout the research process. She currently leads the research arm of several FRAC projects, including a $2 million USDA grant to improve equity in child nutrition programs, and is FRAC's research lead on the WIC Community Innovation and Outreach Grant. In addition, Allison provides general research and analysis that supports FRAC's advocacy to address the root causes of hunger and strengthen the federal nutrition programs. Allison also serves as a community economic development facilitator with the Peace Corps in Costa Rica, 2012 to 2014. Another Central America Caribbean link. Wow, this is awesome. After the Peace Corps, Allison worked for Zufall Health, a federally qualified health center in her home state of New Jersey. She received her BA in Economics, Political Science from Columbia University. In 2020, Allison received her PhD in Nutrition Epidemiology from the Gillen School of Global Public Health at UNC Chapel Hill, where she was a member of the Global Food Research Program, a pre-doctoral fellow at the Carolina Population Center, and a Royster Fellow. In her free time, she loves to try new food and find her rumba on the salsa floor. You need to connect with Heidi. It is our privilege to introduce Dr. Lacko as the second speaker as part of our food series. Take it away.
Thank you for having me today. And sorry, my voice is a little hoarse. I'm getting over a cold, but I'm going to share a couple of resources from FRAC's experience developing, thinking about screening for food insecurity in clinical settings and best practices, and then talk a little bit about the federal nutrition programs specifically, and the, important changes that have helped the programs reduce the impact, the feelings of stigma among participants, and directions that we still need to go that FRAC advocates for. So with that, I will share my screen. So to begin with, a little background about the organization that I work for. The Food Research and Action Center is a nonprofit and a leading advocate for the federal nutrition program. So broadly, the mission is to end hunger, and but through addressing the root causes of hunger. And what we do specifically is work to increase access to the federal nutrition programs, especially with a lens on equitable access to the programs. We do this advocacy work at the federal level as well as the state and local level, and then also thinking about kind of more like wonky programmatic changes that can be made without passing legislation that can improve access to the programs. I don't know what those arrows are doing in the middle of the slide, but our top priorities right now are strengthening the federal nutrition programs. So for example, for SNAP, that looks like improving benefit adequacy, maintaining the fruit and vegetable plus up in WIC, expanding access to healthy school meals for all. Second, guaranteeing that program implementation maximizes available benefits. Healthy school meals for all campaigns are a really good example of that. Supporting policies and programs that reduce poverty and other root causes of hunger. So we've started a lot of advocacy this year around pushing for the expanded child tax credit that expired at the end of 2021, because that has shown to have a really powerful impact on reducing hunger among households with children. Fourth, reduce the racial hunger gap by embedding equity in the federal nutrition program. So making sure that when we're advocating for policy and program changes, we're thinking about the impact on equity and avoiding unintended consequences. And building a national commitment in support of just and effective anti-hunger policies. We have a really large network of organizations throughout the country. So that's some background on FRAC, and the research that I do helps support all of these advocacy efforts. So the next thing I wanted to talk about are some best practices for screening for food insecurity that we've come across in our work. And I'll give the two specific examples of specific projects that we've worked on with pediatricians and then with older adults. But in general, best practices around screening, if you're when screening for food insecurity or really any social determinant of health, and I know that is increasingly a requirement for healthcare settings, but to make sure that the screening is universal, that it's something that you're doing for everybody and not based on perceptions of if you think someone requires access to social programs, and not based on any information you might have about them in their record, but just screening for everybody. Normalizing that hardship happens to everybody, especially coming out of the pandemic. Last month, the poverty data for 2022 was released. Yesterday, the data on hunger in 2022 was released. And both of those reports showed an increase in hardship. So really normalizing that people are going through hard times. We're still trying to adjust to how the cost of everything has risen. And more people than ever get benefits and get a leg up from taking advantage of social programs. The next best practice, using validated tools. So the example for food insecurity screening is the Hunger Vital Sign tool. It's 2 questions and has been validated in a number of populations. It's translated into multiple languages. Rather than, if you're going to come up with your own tool, really thinking through what is unique about your context that would require a different kind of tool, and making sure that you're taking steps to validate that properly. And then lastly, screening with sensitivity. So, that looks like making sure that staff are trained in how to have conversations if you're going to have these, to do this sort of screening face to face. Another option is paper screening. That depends kind of on your patient population and how often you see them, if you feel you have a trusted relationship with them and can have those conversations face to face, or if it's a population that maybe you don't see very often at all and you don't feel confident in that relationship, then maybe a paper screening is better. In some instances, that has been shown to have a lower false negative rate, right? Like people will feel more comfortable just answering something on a piece of paper rather than talking to someone face to face, depending on the relationship that they have with the healthcare system, and making sure that it's done in a private setting too. Best practices for the actual referral process, having a closed loop active referral process. So it's really common to have sort of like a resource pamphlet or folder or paper, a flyer with a bunch of phone numbers, and giving that to patients. We certainly did that when I was at the federally qualified health center. But really thinking about how patient navigators can follow up and make sure that people are taking advantage of programs that they are referred to, and understanding why they haven't, if they haven't, and helping them take the next step. And then as a general workflow process, at FRAC, we really encourage people to first refer to the federal nutrition programs. They're consistently widely available. Sorry, I have to cough. They're consistently widely available, particularly, sorry, I'm ill prepared. My water glass is empty. The Supplemental Nutrition and Assistance Program, SNAP. Okay, third time is the charm. So in particular, the Supplemental Nutrition and Assistance Program is a program that is is a program where there's no funds will be available for whoever applies, as long as they're eligible for the program, and it's universally available. We encourage people to refer patients to these programs at a minimum, because of those systems that are in place. And then after that, adding on other programs and resources like medically tailored meals, or referring people to a community food bank. Those are all really valuable resources. But we do encourage people to refer to the federal nutrition programs first. And then always getting feedback from your patients about your screening process and the resources that you're offering and the follow-up that you're providing is also really important. Next, so really quickly, 2 tools that we have. We have one toolkit that we developed with the American Academy of Pediatrics. It's co-authored by Dr. Kofi Essel and Dr. Kimberly Montez, and they have really been leaders in this space of thinking about how to screen for food insecurity and then successfully refer patients to the programs. So this toolkit can be found on FRAC's website, Screen and Intervene, a toolkit for pediatricians to address food insecurity. And part of the toolkit goes through, I specifically pulled out the page that talks about screening with sensitivity and accounting for the fact that this can be really stigmatizing, especially for parents. Parents face this sort of like, parents and caregivers have this additional layer of already feeling maybe a little defensive about that. There's a lot of stigma already associated with like getting parenting wrong. Like there's already a lot that they're dealing with, and also admitting to experiencing something like food insecurity is not meant to be a reflection on their parenting, but it can certainly feel that way to a parent. And parents also don't want any risk of social services or child welfare being called in their particular circumstance. So there are a lot of particular layers to consider if you're a pediatrician, if you work with, if you're thinking of screening parents for these sorts of needs. And then the other population that we developed a toolkit for were working with older adult patients, which we define as 60 and over, but there are, as you work with older and older patients, there are some other unique considerations to take into account about how those patients might feel stigma. The sort of signs of you may have age-related malnutrition that is different from food insecurity. They're distinct concepts, or they're distinct, and food insecurity can certainly lead to malnutrition. But those are sort of additional health considerations to take into account. Older adults tend to have more comorbidities that food insecurity really has a detrimental impact on. And so that makes addressing food insecurity urgent. And it is the group that participates, at least in the case of SNAP, at a much lower rate than the rest of the population. And stigma is certainly one of the barriers to participating in SNAP. The toolkit goes through, again, sort of like special considerations in this intersection with stigma when working with these patients, and also some of the special rules for SNAP. So it's a toolkit and also a course that you can take for CME credits. So the link is here, and you'll get a copy of the slides later, but it's a really great resource. Some additional resources I wanted to point out. So for the screening tool, the Hunger Vital Sign has a community of practice, and actually they're having their quarterly meeting on November 8th. I just got an email this morning. I was like, what timing? So if you go to their website, you can sign up to join their listserv. They're really great, specifically thinking about screening for food insecurity. Siren has an excellent evidence library of research related to screening for the social determinants of health in general. So if you go to their evidence library, you can filter results by screening, and that they're really great. And in the process of putting together these resources, I came across two resources that I thought were really helpful. This first one is it's a report from the United Hospital Fund, and it names a lot of the best practices that I did a couple of slides ago, but with a lot of quotes from parents that they interviewed in New York City. So, sometimes academic papers that do the same thing, do focus groups, can be like a little dense to get through, and sort of miss pulling out a lot of quotes about what parents are saying. And I think this report does a really good job at sort of synthesizing out the same themes with a lot of quotes from parents throughout. And then the last one was an article that stood out to me because it cites some specific resources related to, like, you want to have these conversations with patients. You're not sure if you have the communication, if you or your staff have the communication skill set to do so. And this paper cited a couple of different tools that seemed to me to be really useful in thinking about, like, how to have, if you're going to have these conversations instead of having patients fill out a piece of paper, how to have that conversation in a sensitive way, because it's not something we just know how to do. Like, these are hard conversations, and training is really helpful. And then my last slide, I just wanted to talk about the federal nutrition programs in a little more detail. There have been some really great changes over the last couple of decades with the child nutrition programs, and especially in recent years, that reduce stigma's impact in participating. The switch to electronic benefits in both SNAP and then recently in WIC. There are a couple of states that still use WIC vouchers, but they're mostly, most states use EBT now, has really reduced stigma during checkout. WIC is a little bit different because you have a specific food package. So you can still have this barrier at checkout, is like the example that Allison gave, where the cashier, there might be some holdup because you're trying to purchase a food with your WIC voucher that is not actually an eligible part of your WIC package. especially as you change, as you go from infant to child, and the sort of what's allowable in the WIC package changes. So WIC still has that complication to it, but the electronic benefits have really made a difference. In terms of school meals, breakfast after the bell and the push for healthy school meals for all has also really helped. And, healthy school meals for all is passing kind of on a state-by-state basis. It's a really good opportunity if you're thinking about like, what are external things I can do outside of interaction with parents on an individual or families on an individual level in a clinical setting. Any state level advocacy for healthy school meals for all to like carry forward the momentum right now for this policy is really, really impactful. And then there are like an increasing number of resources in SNAP and WIC that tailor language and are more tailored to cultural competency. We still have some changes that can be made to SNAP, eliminating the time limits. There are bans for former drug felons and the 5-year ban for adults with legal permanent residency status. Those policies that exclude these groups, these have really important equity implications to them. Reducing administrative barriers, because these barriers can be perceived as deliberately penalizing and stigmatizing to people who use the programs. And then continued training for staff, and not just staff who work in the administrative like arms of the federal nutrition programs, but also for cashiers at stores. But continued training for staff and creation of more culturally appropriate resources. And at the end of the day, any policy change that targets a group or treats them differently or treats poor people differently than everybody else will increase stigma. And at the end of the day, that's what we're fighting against. So with that, I will turn it over to questions. Thanks, everyone.
Thank you both again. I'll go ahead and just start with some of our questions. First is from Rachel Coy from Feeding Texas. Great presentations. Questions for Dr. Karpyn around language and public messaging to reduce stigma. How have can state agencies that run SNAP and SNAP outreach campaigns integrate these learnings? What have you seen that could be strengthened?
I think that's a great question. I haven't studied the different ways that state agencies are articulating the SNAP benefit for people, but I think it's a wonderful idea. I'm sorry, I don't have more information for you on that. Yeah, sorry.
All right, and then Simbo, sorry if I'm saying this wrong, Chiarika said, very enlightening. I'll have to jump off, thanks. Did anyone have any questions they wanted to ask verbally?
I did see that other question here about grocery pickup delivery.
Yes.
I'm not sure if you saw that, Allison. I don't think that WIC is eligible for grocery pickup or delivery in most states, but I don't know.
Not yet.
Not yet. Okay, yeah.
Yeah, there's some pilot states for grain. So I suppose you should, I don't know, if you can online order, can you just pick up your groceries after that? I'm not sure if there's some component for WIC and online ordering where you still have to pick it up in person.
Yeah, Instacart just has started the SNAP where you can do an online ordering using SNAP, but I think they're working on getting the WIC, because there's something, you're right, Allison, but the benefits, and that doesn't allow for the online shopping just yet.
Right.
But Daphne, you had a question.
I do. This was very interesting. I'm currently in the process of trying to develop a food insecurity scale for Hispanic immigrant parents that have limited literacy. And one of the things that I'm considering and really thinking through is whether we should even be asking about, if you think about the USDA and the child questions, whether we should be asking those child questions, because it just causes a lot of fear. I'm not really sure that parents always answer them. Honestly, I had one parent tell me, why are you asking me this question? I immediately thought, oh my gosh, she's going to think I'm calling DHS on her. And it wasn't. Her response was, it's if one person in the household, it doesn't matter who, if one person in the household is experiencing this, it affects the entire household. So just wondering if there's any benefit, just perspectives, especially for those that are studying stigma, whether we should be collapsing some of these questions.
I think that's a really astute observation for immigrant populations specifically. And I think, I mean, in general, if there's food, you're right. If a household reports food insecurity, there's some bias on the part of the parent too, especially because parents will do everything they can to shield their children from food insecurity. But research increasingly shows that children pick up on it, and children know. So even, if it's not affecting their diet quality, it's certainly affecting stress, but it probably is also affecting their eating patterns and what they are telling their parent, how hungry they're admitting that they are, especially older children. So, USDA will still ask the full set of 18 items in the food security question every year when they collect data, but in a small, at a local setting, for just understanding the prevalence of food insecurity, knowing that there are children in the household, and knowing that a caregiver is reporting that sometimes they don't have enough money to afford all the food they want to, is sort of a good baseline. And I would also encourage you to sign up for that Hunger Vital Signs Community of Practice newsletter. Anna Poblacion over at at Children's Health Watch has done a lot of work around developing metrics. And she would be a great person to talk to.
Thank you. I hope your cough gets better.
Oh, poor thing.
Allison, I have a question. Thank you so much, by the way, for a fabulous presentation. We really appreciate it. Allison Karpyn, Dr. Karpyn. What are your next steps on the stigma intervention toolkit for food insecurity? I know there would be a lot of interest in having that resource. I know we'd be interested in partnering on that. Can you share a little bit on what that looks like?
Yeah, we're still in early phases of trying to think through what we would do, but I would actually very much welcome a collaboration, and maybe putting together a little bit of a working group would be a good step. I know Allison in her spare time would also be interested probably in being in said working group, but maybe this is my calling to pull together a larger group. We've had a number of one-on-one conversations about what it could look like, but I think to really do it right, we would need to reach out to many more folks and think about how we could do this more systematically and test it. So I'm happy to get in touch with you.
That would be wonderful.
Yeah.
Thank you.
Sounds good.
I have a question related. I know that and Dr. Karpyn, in your presentation, there was overlap with substance use. I'm just wondering, I guess as we become more conscientious of this, especially in the healthcare space, is it redundant sometimes to focus on one social issue or not address poverty altogether in the metrics?
I think we can't address really any social issues without addressing poverty. I mean, they're just so intertwined. And you're right. I mean, on the same block where we have a lot of our community garden work happening, it's clear there's also opioid use disorder and other, issues around violence. Everything kind of comes together in similar spaces. So you can't separate them. I agree, Wes. Yeah.
And Melissa posted in the chat, it looks like the USDA is proposing a change to their program rules to expand WIC access to online shopping, similar to how SNAP is. So that link's in the chat if you want to click on it.
I'm wondering if there are any interventions that y'all are aware of reducing stigma. You know, you kind of mentioned the societal level of talking, us individually talking more, but are there other maybe more targeted interventions, looking at change at the organizational level or the provider level, particularly in light of the new quality measures requiring screening for social determinants of health in the healthcare space next year? I'm thinking of the implications there and preparations there, I suppose. For either of you.
Yeah, I mean, I just kind of echo Allison's like foundation. I mean, the basics that we know, at least from like school meal programs, it's just where I feel like we have most of our footing on this issue, more so than perhaps in the grocery retail space or even in physician practices or hospital settings. You know, it's more relatively new, these screenings, is just the idea that what happens to one happens to all. And the more consistently that we can implement either program offerings or questions about what people need, or, you know, the way that we screen for things as consistently and across the board as possible, I think is really one of the biggest rules of thumb. And then obviously, as we mentioned, and I see the comments too about, you know, language, and then people just in general feeling more comfortable to speak about their own program participation if that was part of their upbringing as well. I mean, we know, right? WIC has the potential to reach at least half, if not more, children in our country. And so, you know, many of us are the product of these programs. Yeah.
Thank you.
Well, I just want to thank everyone for attending. And real quick, I just also want to let people know, if you're new to a lot of the conversation going on, there's a way to get connected to other resources. We're part of the Center for Health Equity, which has 3 layers of engagement, intelligent infrastructure. And a big part of our infrastructure is the Health Equity Collective, where we're here now. We have an in-person event coming up in November. I put the flyer in the chat, but I'll also put it here on the screen. We welcome you to attend, celebrating our 5-year anniversary. Also put up the YouTube chat. We have a YouTube channel too, where we have this session along with others we've discussed and a lot of other topics. And the last thing I'll put in the chat is Mighty Networks. That's a good way if you want to see a lot of our resources archived or get involved more. We definitely welcome that. But yes, thank you again to everyone who attended. Thank you again, Dr. Lacko, Dr. Karpyn, for attending. It was great to see a big turnout, and we just welcome continued involvement from everyone in this space.
Thank you all. Bye-bye.
Thank you.
Everybody.
Thank you so much.
Thank you, everyone. Thank you.
Thank you.
Bye.